The Xyrem helps them get into stage 3 and 4 sleep during the evening. I think we've gone into the substrate issue in little depth. I do want to speak just a second more on obstructive sleep apnea. Some physicians are hesitant to treat mild obstructive sleep apnea as though mild obstructive sleep apnea is a mild issue. Here again, any condition that's capable of causing you death is not a mild condition. I think of mild obstructive apnea like mild pregnancy. If you're the woman and you're pregnant, I doubt you'll ever consider that delivery mild. If you're a patient with obstructive sleep apnea and you have mild sleep apnea scoring on your sleep study, the amount of fatigue, the amount of adrenaline issues, the amount of blood vessel issue problems would rarely be called mild by the patient. One of the reasons physicians are missing this diagnosis, they're not doing their physical exams carefully in this area. When you see the drooping soft palate, that is the number one reason patients have obstructive sleep apnea. Quite commonly, the uvula is enlarged or sitting on the tongue. They have small little allicin pictures on this oral exam. You see the little eye on each side of the uvula. That would basically be a patient at high risk for obstructive sleep apnea. Now, one of the reasons you may miss this is you stick a tongue depressor in the mouth and you have them say, ah. When you have them say, ah, the levator veli palatini muscle is lifting the soft palate in such a way that you don't notice how far their palate is drooping. Instead of doing the tongue depressor in the ah, use the tongue depressor and have them breathe through their nose. That will cause the soft palate to relax. The levator veli palatini muscle lets go of the soft palate, and then you can see how far it's drooping. An enlarged tongue is a tongue that touches each side of the oral crease of the mouth. If you stick the tongue out of the mouth and the tongue is touching on both oral creases, you've got an enlarged tongue. If you've got a tongue that sticks out and seems to go on and on, you have an elongated tongue, and either one of those physical characteristics increases the likelihood of obstructive sleep apnea. If you notice the nasal passage on this female in this picture, she has nasal occlusion on that left side. If you watch my nose when I breathe in, same thing. If you have intranasal occlusion on both sides, the patient has obstructive sleep apnea until proven elsewise. When you work with patients with CPAP or BiPAP for these obstructive sleep apnea cases, they need coaching. Sometimes they go through the first few weeks of treatment and they struggle. If you send them back to the sleep lab for what's called a PAP nap, that's P-A-P-N-A-P, the PAP nap, the sleep technician watches them for about 3 hours. They go to sleep with the equipment on. They tell the sleep tech what they like and what they don't like about the mask and the various things going on in the room. They one by one help them with that. They might change a mask and they say, oh, that feels better, but this bothers me here. They change the mask again. Say, well, I like that, but I don't like the air blowing here. And they change again several times until eventually they find just the proper mask that's the most comfortable for that patient to sleep with. It may be they have trouble with anxiety or claustrophobia. There's various masks, there's various ways of handling that. The sleep technician can inform the doctor that's in charge of the sleep case with what was effective and how to make this patient go home and have higher levels of success. You can get more done in a PAP nap than you can get done in multiple clinic visits, simply because of how much can be done within a 3-hour time period within this patient's specialty, within the sleep tech's specialty of taking care of patients. When your patient comes in with obstructive sleep apnea and they're on a CPAP or BiPAP, they have a smart card in their machine. Please download it and see if they're wearing the machine, see if it's working effectively, see if their mask has large leaks of a significant nature. If a large leak is occurring over 30 minutes, they probably need a new mask. They might just need tightening of the Velcro. If you see these bars going up past the line there, that means they've slept more than 4 hours, and that's usually considered a modest success with the ability to make chemicals in the sleep apnea patient. If that bar is black, that means the machine is turned on, but they're not wearing it. If the bar is green, that means the machine is turned on and they are wearing it. If the bar is red, that means they wore it, but they didn't quite get to 4 hours. You want to see your patients getting this machine on as close to every night as possible. You encourage them to travel with it. It goes where they go. And then they get effective sleep. The purpose of sleep is to make brain chemicals. It makes no sense to sleep without this machine. I explain to my patients, when you choose to go somewhere without this machine, that's like going to the gas pump when your car is empty in gas and just sitting in your car for 10 minutes and then driving off but never pumping any gas in your car. Makes no sense. Your tank's empty, you're there at the gas station, get out of your car, pump the gas. However, if you were to do that and just drive up the station and leave, that's the same thing as a person with sleep apnea going to sleep but not wearing their CPAP. They go to sleep. The purpose of sleep is to make chemicals, but they spend all their night in stage 1 and 2, 1 and 2, 1 and 2. They never get into stage 3 and 4 adequately. They don't make chemicals because that's the only place you make chemicals is in stage 3 and 4. Thus, they just drove up to the gas pump and didn't fill up. Chronic kidney disease. We're seeing more and more of this. Certainly, the worse the disease is, the more increase in morbidity and mortality of these patients. From a cardiovascular perspective, I'm a strong proponent of using cystatin C in your yearly physical exam blood work and picking up on chronic kidney disease in the early stages rather than the late stages. Screen these patients for hypertension, diabetes, dyslipidemia, and other cardiovascular parameters in that 8 disease state model. Make sure that you're getting microalbumin to see how much protein they're spilling simultaneously. Realize when an albumin to creatinine ratio is above 5, you're developing cardiovascular disease. When it's higher levels, like you might see on multiple lab reports, we're talking about renal issues and the albumin creatinine ratio. But a level above 5 would be substantial in the cardiovascular arena. How do you stage chronic kidney disease? You can see microalbuminuria with an estimated GFR greater than 90 would be stage 1. Microalbuminuria with an estimated GFR from 60 to 89, stage 2. That estimated GFR of 30 to 59, stage 3. Estimated GFR of 15 to 29, stage 4. Less than 15 estimated GFR would be stage 5 in dialysis. Now, as this disease progresses, you're going to have to be more and more aggressive so you can help your patients avoid dialysis. I have a number of patients that have had stage 4 chronic kidney disease for as much as 10 years or more. And how would you do that when the national average would probably be closer to 9 months? If you have a patient with advanced chronic kidney disease such as stage 4, you want to maintain their fluid balance in an aggressive manner. Never let them get dehydrated. If they have a stomach virus, insist they go to the emergency room and get several liters of fluid rather than just riding it out at home. If they go outside and work in the hot summer sun and realize they sweat too much, if they can't properly rehydrate themselves orally, they go to the ER and get some help in that regard too. They also take proper medications that protect the kidney. They don't allow their blood pressures to get below a certain point and cause further issues. You do want to control these patients' blood pressure, just not over-control to the point where their systolic blood pressure would be less than 90. You see here on this study where statin therapy was used, there was improvement in these patients' chronic kidney disease and outcome in cardiovascular disease when you added atorvastatin. There was also further improvement when you combine the two. We're soon to go into treatment of clinical cases. I think this is wonderful that we've had this chance to discuss the biomarkers to this point. I want to make some practical application of this so that this is more than a bunch of numbers.